Hi, everyone. Thanks for joining us today. Welcome to the Endocrine Society's virtual ENDO 2021 news conference on COVID. My name is Colleen Williams, and I'm the Manager of Public Relations here at the Endocrine Society. Before we get started, I'd like to go over just a few housekeeping items. Journalists may type their questions into the chat window at any point during the news conference, and they will be addressed during the Q&A at the end. Please be sure to include your name and affiliation with any of those questions. This press conference is being recorded, and recordings will be available on endowebcasting.com and the Society's YouTube channel, as well as our website following the presentation. We are pleased to have with us today Dr. Yumi Kang of Yale New Haven Health in Connecticut, Dr. Samira Swirsky of the State University of New York Downstate Medical Center in Brooklyn, New York, Dr. Manish Razangani of the University of Arkansas for Medical Sciences and Arkansas Children's, as well as Dr. Shweta Shakuri of Montefiore Health System and the Albert Einstein College of Medicine in the Bronx, New York. Over the next 30 minutes, each speaker will present their findings, and then we will end with a Q&A session. I would now like to invite our first presenter, Dr. Kang, to speak.
Thank you for your kind introduction. I would like to thank the Endocrine Society for this opportunity to participate in the conference. The title of our study is Obesity is Associated with Intensive Care Use and Duration of ICU Stay, but Not Mortality among 3,246 patients hospitalized with COVID-19. Next slide, please. Obesity is a common comorbidity during the COVID-19 pandemic, and studies suggest that it increases vulnerability to COVID-19. However, the mechanisms through which obesity increases the susceptibility to SARS-CoV-2 infection or worse COVID-19 outcomes are yet to be elucidated. Most of the earlier studies had various designs and sizes, and a short-term follow-up period, and variable accuracy of BMI data. So we aim to determine the association of obesity with outcomes among patients hospitalized for COVID-19 using a large cohort with calculated BMI. Next slide, please. We used Yale Department of Medicine COVID Explorer database, which is an electronic medical record data within the Yale New Haven Health System. This database contains clinical information across 5 hospitals in our health system across Connecticut and Rhode Island. We included patients that were 18 or older, hospitalized between March and September 2020, and who had positive SARS-CoV-2 PCR tests confirmed between 14 days prior to admission until the date of discharge. A total of 3,246 hospitalized COVID-19 patients were enrolled in our study as a result. The primary endpoints were in-hospital death or transition to hospice care, ICU admission, and the length of ICU stay. We used the first weight on admission or the most recent weight within 90 days of admission, followed by manual chart review for the optimization of BMI. The WHO classification of obesity here shown in the table was used to define obesity. Next slide, please. This is a table describing the baseline characteristics among patients based on their BMI. The first row shows the proportion of people hospitalized with COVID-19, and less than 1/4 had normal weight, whereas 43% fell into the obesity category. The second row shows the median age in each group, and the median age of all hospitalized COVID-19 patients was 65. For those that were underweight, it was 78.5. The normal weight had the median age of 78.5. The normal weight had 75. Then it was 10 years younger in the overweight category. Then lastly, the individuals with obesity had the lowest median age of 59. Those with obesity were more likely to be female and more likely to have diabetes at baseline. Next slide, please. This is a graph that describes the crude incidence of ICU admission and mortality. The x-axis shows each BMI category, and the y-axis describes the crude incidence of our primary endpoints within each BMI group. So the blue bar shows mortality rate and the orange bars show the ICU admission rate. For all comparisons, the normal weight group was the reference group. A total of 16.7% of our hospitalized COVID-19 patients died or transitioned to hospice care. Compared to the normal weight group, the underweight group showed the highest crude mortality rate. Mortality across obesity class did not go up. In fact, it was lower than normal weight subjects. But I would like to remind you that these were the unadjusted analysis and that patients with obesity tended to be younger. If you look at the orange bars behind that shows the ICU admission rate, a quarter of our entire hospitalized patients were admitted to the ICU. And the obesity showed a significantly higher crude ICU admission rate compared with the normal weight group. Next, please. When we divide the obesity group into class 1, 2, and 3, we were able to see this graded increase in the ICU admission with the obesity class, and the highest ICU admission rate was seen among those who had class 3 obesity. Next slide, please. These forest plots display the multivariate adjusted odds ratios for ICU admission and mortality. Each analysis was adjusted for age, gender, race, ethnicity, diabetes, chronic kidney disease, cardiovascular disease, neurological disease, liver disease, hypertension, immunosuppressive therapy, and respiratory disease. As seen on the left forest plot, obesity as a whole, as well as class 2 and 3 obesity, were associated with an increased ICU admission, with normal weight group being the reference group. However, as seen on the right forest plot, neither the obesity as a whole nor any class of obesity showed a significant association with in-hospital death or hospice care. Next slide, please. This graph illustrates the length of ICU stay described as an average number of days according to their BMI. All patients who were admitted to the ICU stayed in the ICU for approximately 8.5 days on average, and normal weight COVID patients stayed in the ICU for 6.6 days on average. Compared with this, patients with obesity showed a significantly increased length of stay by almost 3 days. And when the obesity group was divided into the 3 classes, it showed an incremental trend across the 3 classes. And class 3 obesity had the longest days in the ICU, which was 10.2 days on average. Next slide, please. In conclusion, obesity is associated with a more severe COVID-19 hospital course, including a higher rate of ICU admission and longer ICU stay, but not with increased mortality. This underscores the vulnerability of individuals with obesity during the current pandemic and emphasizes the need to ensure that obesity is given appropriate consideration in COVID-19 prevention and management. These include having a reliable risk stratification method, which could be further applied to vaccination guidelines and COVID-19 management protocols. I would like to thank you for your attention, and I'll be glad to answer questions at the end.
Great, thank you so much, Dr. Kang. I would now like to invite Dr. Skorsky to present her research.
Hi, my name is Samara Skorsky, and I'm a second-year internal medicine resident at SUNY Downstate Medical Center. Today, I will be speaking about our study, Sugar is Not Always Sweet, exploring the relationship between hyperglycemia and COVID-19 in a predominantly African-American population. Next. So since the start of the pandemic, there have been over 28 million cases of COVID-19 in the United States, with over 500,000 deaths to date. In New York City alone, there have been over 700,000 cases. It has been reported that the African-American population has been disproportionately affected by this virus and are actually approximately 2 to 3 times as likely as white Americans to die from COVID once infected. As you can see in the graph to the right, in New York City, Blacks had 300 deaths per 100,000 compared to 178 deaths per 100,000 in the non-Hispanic white population. Given the high prevalence of diabetes among Black patients, one might wonder how a prior diagnosis of diabetes could affect outcomes in patients with COVID-19. A few studies conducted during the height of the pandemic have identified both diabetes and hyperglycemia independently as risk factors for worse clinical outcomes in COVID-19. However, no studies to date have focused on this relationship in African Americans. The purpose of our study is to explore the relationship between admission hyperglycemia in patients hospitalized with COVID-19 and clinical outcomes in a majority African American population. Next slide. So for our methods, we performed a retrospective cohort study of all COVID positive patients admitted to SUNY Downstate Medical Center from March 1st to May 15th, 2020. SUNY Downstate, which was designated as a COVID-only center by Governor Cuomo in the beginning of the pandemic, is located in East Flatbush, Brooklyn, a neighborhood in which 88% of its population are non-Hispanic Black. Data including patient demographics, clinical characteristics, and outcomes was collected from the hospital's electronic medical record system. Multivariate logistic regression analysis was used to calculate adjusted odds ratios for outcomes of mortality, intubation or being placed on a breathing tube, intensive care unit admission, and acute kidney injury based on prior diagnosis of diabetes and admission blood glucose levels. A multiple linear regression analysis was also performed for the continuous outcome of length of stay. Next slide. So as you can see, of the 982 patients hospitalized during the study time period, 708 patients tested positive for COVID-19 and were included in the final study cohort. Patients were excluded if they tested negative, were less than 18 years of age, or if there was insufficient data for analysis. These patients were further divided into subjects with and without diabetes, and then again by admission blood glucose greater than 140 or less than 140 and greater than 180 or less than 180 milligrams per deciliter. The admission blood glucose levels of 140 and 180 were chosen based on the current American Diabetes Association guidelines, which recommends a target glucose of 140 to 180 for most patients during hospitalization. Next slide. So here are the baseline characteristics and overall clinical outcomes of our study cohort. Of the 700 patients included in our study, 89% were Black. The mean age of the study cohort was 68, with 62% of patients greater than 65 years of age. 383 patients, or 54% of the cohort, had a known history of diabetes. As far as overall clinical outcomes, there was a 40% crude mortality rate among our study cohort. Next slide. Okay, so as you can see, this table shows the adjusted odds ratios for the association between admission glucose levels and outcomes in patients with and without diabetes. These odds ratios were adjusted for age, sex, BMI, white blood cell count, creatinine, history of hypertension, cardiovascular disease, and chronic kidney disease. The bolded values are the odds ratios that were found to be statistically significant with p-values less than 0.05. Overall, hyperglycemia on admission resulted in worse clinical outcomes in patients hospitalized with COVID-19 with and without diabetes. Patients with diabetes who had an admission glucose greater than 140 compared to those with glucose less than 140 had a significantly increased odds of intubation and ICU admission, whereas those with an admission glucose greater than 180 had an increased odds of mortality alone. In comparison, patients without diabetes with an admission glucose greater than 140 had an increased odds of mortality, ICU admission, intubation, and AKI, whereas those with glucose greater than 180 had an increased odds of mortality, ICU admission, and intubation. Of note, we also explored the relationship between admission glucoses of 140 to 180 and mortality in patients with and without diabetes. However, the results were not statistically significant. Next slide. So to put these results a different way, you can see here the adjusted odds ratios for admission glucose and inpatient mortality. Again, hyperglycemia is linked to a higher risk of death in patients with and without diabetes. Specifically, we found that patients without diabetes presenting with a glucose greater than 180 had a 4-fold increased odds of death, whereas those with a history of diabetes and glucose greater than 180 had only a 1.8 increase fold of death. These findings are consistent with other studies published prior to the COVID pandemic, which found a greater association between hyperglycemia and mortality in patients hospitalized without a prior diagnosis of diabetes. Next slide. Despite our results, it is still unclear whether hyperglycemia is the result of or a cause of more severe COVID-19 illness. These results raise the testable hypothesis that intensive glucose control with more frequent monitoring and treatment with insulin to a target glucose of less than 140 could improve outcomes in patients hospitalized with COVID-19. However, additional randomized control trials are still needed. Although our study is retrospective in design, the results are consistent with the current Endocrine Society guidelines, which recommends that all patients hospitalized with blood glucose greater than 140 be monitored and treated with appropriate therapies. One limitation that should be noted is that given the majority of our study population did not have a hemoglobin A1C level available within 6 months of admission, it is possible that some patients with latent or undiagnosed diabetes on admission were misclassified as non-diabetic. Next slide. In conclusion, our findings suggest that patients with COVID-19 who present with high blood sugar require closer observation and more aggressive therapies, regardless of prior diagnosis of diabetes. To our knowledge, this is the first known study of the impact of hyperglycemia on a majority Black African-American population with COVID-19. Thank you all very much for listening. I will be available for questions at the end.
Great, thank you so much, Dr. Swirsky. I would now like to invite Dr. Razangani to present. If you could just go off mute, Dr. Razangani. Thank you.
Yes, so today I'm going to speak about risk of complications in children with adrenal insufficiency and COVID-19. Next slide, please. So I have no relevant financial relationships to disclose. Next slide, please. So let's talk a little bit about the COVID-19 pandemic and adrenal insufficiency. The COVID-19 pandemic started in 2019, as we know. Adrenal insufficiency occurs due to lack of cortisol production by the adrenal gland due to a central issue or an adrenal issue. Children with adrenal insufficiency are unable to mount a normal stress response to infections, and this can put these kids at a higher risk of complications with infections. These children with adrenal insufficiency are often prescribed a higher dose, stress dose steroid, which they take when they have infections, anesthesia, or any significant events. There is very limited data available in pediatric adrenal insufficiency and COVID-19 infections. So let's look at the next slide. So we looked at this database called the Trinetics database. Trinetics is a large COVID-19 international database. It collects information from over 60 healthcare organizations across the world in 31 different countries. And then we compared children between the ages of 0 and 18 who were diagnosed with COVID-19 with and without adrenal insufficiency for complications including mortality, sepsis, and intubation. Next slide, please. So this is just looking at kids without adrenal insufficiency and with adrenal insufficiency with COVID-19 infections. So in the second column are kids who were diagnosed with COVID-19 infections and had no adrenal insufficiency. Here, if you see, there were over 600,000 kids who were diagnosed with COVID-19, out of which there were 215 deaths, with a relatively low percent risk of mortality of 0.03. While if you look at kids who had the diagnosis of adrenal insufficiency in the chart at least a month prior to the COVID-19 infection, had a much higher risk of mortality. The relative risk was almost 23 times. Now, I think one reason why the relative risk is so high is a lot of these kids with adrenal insufficiency also had respiratory illnesses, lupus, and a lot of them had secondary adrenal insufficiency because they have been on chronic long-term steroids. So these other illnesses also contributed to this. Now, if you adjust for all respiratory illnesses as well as other illnesses, this relative risk comes down a lot lower to about fourfold. So adrenal insufficiency can independently be associated with higher risk of mortality, independent of other medical issues. Next slide, please. Again, this is a slide talking about sepsis. In the second column, you can see that the risk of sepsis in kids without adrenal insufficiency was quite low at 0.09%. But again, kids with adrenal insufficiency had a much, much higher risk of sepsis. Again, a very, very higher relative risk seen in red. But as I mentioned before, there were other contributing illnesses. And if you adjust for that, this number comes down to about threefold. Next slide, please. This is intubation rates among kids without adrenal insufficiency and with adrenal insufficiency. Again, a very low risk of 0.02% risk of intubation in kids without adrenal insufficiency. And moving on to the last column, you can see it's a 0.75 risk. Again, a much, much higher relative risk if you have any history of adrenal insufficiency. Next slide, please. So in conclusion, I would like to say that adrenal insufficiency with COVID-19 puts kids at higher risk of complications. Mortality rate, endotracheal intubation, and sepsis are all increased in kids with adrenal insufficiency and COVID-19, even after adjusting for other respiratory illnesses. Hence, it is very important for children with adrenal insufficiency to take precautions during these times, to take their medications properly, as well as take their stress doses properly. Now, one limitation of our study is we did not distinguish between primary versus secondary adrenal insufficiency, as well as, due to exogenous steroids, because I think that probably will change the data a little bit, especially in kids who have many more comorbid conditions. Thank you for your time, and I'm happy to take questions in the end. Thank you.
Great, thank you so much, Dr. Rajangani. I would now like to invite Dr. Shakuri to present her research.
Hi, I am Dr. Shweta Chakori, and I'm here with Dr. Sarah Barron. Today, we're going to be speaking about pre-admission vitamin D supplementation in patients with low 25-hydroxy vitamin D may improve COVID-19 outcomes. So for background, vitamin D supplementation has demonstrated utility in non-COVID-19 respiratory illnesses such as influenza and RSV. There are limited, inexpensive, and effective COVID-19 treatment options. Physicians are repurposing existing treatments that we use for other diseases, such as vitamin D. The aim of our study is to answer this question. Among patients with low 25-hydroxy vitamin D, is vitamin D supplementation prior to hospitalization associated with less severe outcomes in COVID-19? For our methods, the population we used is all adults with COVID-19 admitted to Montefiore Medical Center between March 11, 2020 and June 2nd, 2020, and with the pre-admission 25-hydroxy vitamin D of less than 30. The variable of interest is receipt of at least greater than equal to 1,000 units of vitamin D, either cholecalciferol or ergocalciferol weekly. For the outcome, we looked at severe COVID-19 disease, which is defined as mechanical ventilation or death. For subgroups, the subgroups we looked at were those with insufficient, defined as 25-hydroxy vitamin D level between 20 to 30, versus deficiency, defined as 25-hydroxy vitamin D, defined as a level less than 20. The additional subgroup we looked at are patients who were supplemented at least greater than equal to 5,000 units of cholecalciferol or ergocalciferol weekly. For the results, we had a total of 124 COVID-19 patients with a serum 25-hydroxy vitamin D level of less than 30. of which 64 were not supplemented with vitamin D, and 60 were supplemented with at least 1,000 units weekly of vitamin D, which is cholecalciferol or ergocalciferol. The median age of patients was 64 years, predominantly female, with 46.8 being male, and they were predominantly Hispanic, 46.7%. The median BMI was 29.1, which puts most of our patients as overweight or obese. For results, in our primary outcome, we noted vitamin D supplementation with greater than equal to 1,000 units weekly had no significant effect on severe COVID-19 in the unadjusted or adjusted model. As you recall, we defined severe outcome as mechanical ventilation or death. The odds ratio unadjusted was 0.83 and the adjusted was 1.2. In our subgroup analysis, which was also not significant, but we noted lower odds of severe COVID-19 outcomes in the unadjusted model for those patients deficient with 25-hydroxyvitamin D. This also held true when supplementation was greater than or equal to 5,000 units weekly. This graph shows severe COVID-19 outcome by supplementation status. You can see we have this stratified by 25-hydroxyvitamin D level. On the y-axis represents the percentage of severe outcomes, which is mechanical ventilation or death. The blue bar represents patients who were not supplemented with vitamin D, and the pink bar represents those who were supplemented. On the left are patients who are deficient in 25-hydroxyvitamin D, which is a level less than 20, and to the right are the insufficient with a 25-hydroxyvitamin D value 20 to 30. As you can see, in patients on the left in the deficient group, which is less than 20, 39.1% of those not supplemented had severe COVID-19 outcomes, but only 25% of those supplemented had severe COVID-19 outcomes. Again, this difference was not statistically significant. Next slide. This graph demonstrates the same information, but rather than using 1,000 units of supplementation, we limited this data to greater than or equal to 5,000 units of vitamin D supplementation weekly. Similarly to the last graph, we noted less severe outcomes in patients who received supplementation. So 39.3% of the patients who had no supplementation had severe COVID-19 outcomes, and only 21.7% of those supplemented had severe COVID-19 outcomes. Again, this difference was not statistically significant. Based on these findings, though it was not significant, our data demonstrated a difference in severe COVID-19 outcomes based on vitamin D supplementation. This effect was more pronounced in patients with a pre-admission 25-hydroxyvitamin D less than 20. Only half of our patients in this study with a 25-hydroxyvitamin D level less than 20 were supplemented. It may be prudent for providers to prescribe vitamin D supplementation to any patient at risk for COVID-19 with a 25-hydroxyvitamin D level less than 20 per our research. Thank you for listening. Here's our contact information if you would like to send us any questions, and we'd be happy to take any questions at the end.
Great, thank you so much, Dr. Shakuri. I'm now going to turn it over to my colleague Jenny to kick off the Q&A and read a few questions that we've gotten from our journalists.
Great, we have a question for Dr. Kang. It's from Mike Renostra at Endocrine Today. He asks, were there any factors that may have contributed to obesity not being associated with increased COVID-19 mortality?
Thank you very much for this important question. It is not clear why we saw this significant association of obesity only with increased ICU admission and longer ICU stay, but not with increased mortality. But I could think of a few points which might explain this. The first is that we were fortunate to have more lead time to gather up resources and learn from other countries and states' experiences that were struck by the pandemic first. And these made us to hire more healthcare providers, expand floor and ICU beds with negative pressure equipment, and gather all ventilators across the healthcare system. And in addition to that, we received frequent updates on COVID-19 management protocols by our health system. These were mainly based on the rapidly emerging reports from those other states. One of the good examples is that our protocol recognized BMI greater than 30 as one of the criteria among numerous other risk factors, of course, to introduce COVID-19 targeted therapies. And indeed, we observed a higher proportion of steroids, tocilizumab, or remdesivir use in patients with obesity compared with normal weight patients among our patients. And this might have influenced and maybe mitigated some effects attributable to obesity, although this needs further investigation. And probably the relatively low prevalence of obesity among adults that were 75 or older could explain why we'd not observe association between obesity and mortality. But in the multivariate analysis, we did adjust for age, and it is one of the strong risk factors for mortality in COVID-19, according to numerous studies. So these might explain why that was the case.
Great, thank you for that thoughtful response. Dr. Skwersky, I have a question from Miriam Tucker at Medscape. She asks, is measurement of HbA1c routine at hospital admission? And if not, does the pandemic suggest maybe that practice should be instituted in order to distinguish people with undiagnosed diabetes from those with stress hyperglycemia caused by illness? And did you have any data regarding blood glucose levels at discharge?
So this is a really great question. So to answer that question, the measurement of A1Cs are not exactly routine for every patient during hospital admission or on hospital admission, but it is often done at some point during the hospitalization in a person who does present with hyperglycemia. But I think during the time of crisis, as was the COVID pandemic, it wasn't as frequently done as we would have liked. And I agree. I do think that it would be helpful to obtain A1Cs on admission to differentiate between, again, stress hyperglycemia and versus just undiagnosed diabetes. Also, we don't have the data for glucose on discharge because it was retrospective, but I think this would be very helpful to better understand the role of hyperglycemia in the COVID virus.
Great. And Dr. Skwersky, I actually have one more question from you, from Fabiano Serfati, who writes for Medscape's Portuguese and Spanish language channels. He asks, can the difference in outcomes in diabetic and non-diabetic patients be due to the use of metformin? As we know, metformin is the most used medication in diabetes, since we already have scientific evidence that its use may be associated with reduction in mortality in diabetic patients.
That is a really great question. I'm not exactly sure the answer to that because I know there were some mixed studies on metformin, but I would be glad to get back to you at a later date via email.
Great. See, that's all we have in the window right now, but while we're waiting, Dr. Raisangani, I know you and I both talked about being parents of young children. I was curious for parents who have children with adrenal insufficiency, do you have any advice for them as they're thinking about, a lot of people are thinking about, is this the time to go back to school?
Yes, I mean, that's a very important question because parents have to decide, is it safe to go back to school? Because it's important to go to school to, for social development of the kids. So it's really important that you take your hydrocortisone medications very well, start stress dosing as soon as you're sick. So this will kind of help prevent significant complications due to COVID-19 or any other infections. A lot of the complications that we see in kids with adrenal insufficiency is due to inadequate stress dosing of steroids. Parents should also be re-educated about using the emergency injection of hydrocortisone as needed at home. And I think all these measures should help prevent have significant complications due to COVID-19.
Great, thank you. And Dr. Chakuri, I have a question for you. How does someone know if they're vitamin D deficient and they should start thinking about whether to take supplements? Should those with an underlying condition be thinking about this, or older people, should they be prioritized?
I'm going to take that question. This is Dr. Barron, and thank you so much. It's a fantastic question. There are actually, I would say, there is some controversy around this question of who should be checked. Most patients who are not symptomatic do not need their vitamin D level checked or their 25-hydroxy vitamin D level checked. That said, there are groups of individuals, some of them are older patients, institutionalized patients, people on certain medications who often should have their levels checked, and they can speak to their providers, their endocrinologists if they have them, or their primary care doctors who will be able to, really decide what their risk is for having low vitamin D. And I think that what our work shows, our work was, again, retrospective data, evaluating patients whose own providers determined that they needed that level checked. And unfortunately, what we saw and what we see in other studies as well, this is not unique to our work, is that many of the patients whose levels were very low really were not supplemented. They didn't receive appropriate supplementation. So this won't be news to any of the endocrinologists on the line or to any of us that if you check a lab, right, we need to have the appropriate response to it. And all that we've shown is that having the appropriate response to low levels might actually be protective. In addition, for all of the other reasons that we were using vitamin D, it might actually protect against severe outcomes in COVID-19. So if you need a level checked and you get it and it's low, supplement.
Thanks, Dr. Barron. I was actually curious, this is such an interesting emerging topic, and we are seeing a lot of different research coming out on vitamin D and COVID. I mean, what do you think still needs to be researched? What questions do we still need to answer?
Again, it's a great question. I think that what we're seeing more and more of is vitamin D with COVID is a really fascinating area of research, and there are, active controlled trials happening about giving vitamin D to patients with COVID. Partly why we wanted to do this was because we really felt like maybe it was the, pre-COVID moments. We looked at patients who were supplemented really prior to any diagnosis of COVID, prior to hospitalization. And the question is, do patients who have low levels do better if we actually helped get them to a normal level or closer to a normal level previously? And I think that as with much of the COVID work and literature happening now, the question is, how do we move back our treatments from when someone is so sick to whether we can prevent that severe illness? Never mind maybe preventing the whole illness, that's what vaccines are for, but can we prevent the severe complications, which I would argue include hospitalizations?
Great, thank you. That's all the questions I see in the queue.
Awesome, thanks so much, Jenny. And thank you to all of our speakers and all the journalists that joined us today. We appreciate you taking the time to listen in on this discussion. As a reminder, the recordings will be available on our website and YouTube channel within a few hours following this. But if anyone has a specific question or needs any help setting up an interview, please feel free to email us at media@endocrine.org, and we'll be happy to help you. So with that, thank you all so much for joining today.